I'm a speech pathologist of long standing. I work at Beaumont Hospital. Very proud of the Michigan Parkinson Foundation and all that we've done. When I got on the board, we had like 20 support groups. Now we have 76. So we're doing terrific and very proud of all the activities we have. Today, I have Jenny Maurer with me, and Jenny is also a speech pathologist, and she works at Beaumont at our outpatient clinic, and she does the LSVT, the Lee Silverman voice treatment technique. I don't. I do a traditional technique. I call it the RMTT, the Rick Merson total treatment. So we do both at Beaumont Hospital, and it really depends upon what you need. I wanted to show you some pictures of famous people who have Parkinson's, like yourselves. You're all very famous. But what I wanted to point out was that many of these people continue to work. Michael Fox, Muhammad Ali, and Kirk Gibson is still working. And many people with early stage Parkinson's, first and second stage, can still continue to work and do quite well. And we're pleased to be a part of that. Remember Janet Reno, she was the Attorney General. She continued to work. Even though she had signs of Parkinson's, she did it very well, and she could complete her job. And an astronaut, we had an astronaut who had Parkinson's disease, and he actually went up in orbit with his Parkinson's disease and did quite well. And of course the Pope, you remember the Pope, we all love Pope John. And he had Parkinson's, and he was a magnificent communicator, and even though he had many difficulties with the Parkinson's and mobility, he still completed his job with great skill. And now Neil Diamond, a couple months ago, reported that he also has Parkinson's, and I'm sure he still sings to himself and his friends and at home, but he's decided to retire from singing concerts, but he's still performing. Well, this is a difficult slide to see, but what it demonstrated is the incidence, the prevalence of Parkinson's disease is going to increase significantly because our population is going to age. And this is a big study that Canada did a few years ago. They wanted to examine what was the prevalence of all the neuropathologies in Canada. Canada is about a tenth the size of the United States. Has about 35 million people. We have 350 million. So if you take some of the results that the Canadians reported, you could probably times it times 10. So over in Canada, they were looking at 83,000 patients who had Parkinson's disease in 2011, and by 2031, they think that population is going to double. Well, we have 1.5 million people in the United States with Parkinson's, so I think that in 2031, we're probably going to have close to 3 million people, and that's going to make Michigan from 35,000 today approximately. We're going to close in on as many people who have Parkinson's in Canada will have it in Michigan. That's a big population to manage and take care of, and that's what I wanted you to see. And then I wanted you to see this. Many of you know this already, but that the incidence of Parkinson's, the prevalence really presents itself in the 60s. Some people show it earlier in the 50s or 40s. That's highly unusual. A large percentage really show in the 60s, and you can see that slope increase in the 70s and 80s, that both men and women increase in Parkinson's as we age. So Parkinson, the phenomena of Parkinson's, the loss of dopamine in the brain probably increases naturally as we get older, and men a little bit more than women. Many, many years ago, in 1972, I was a young speech pathologist at the Mayo Clinic, and I treated a lot of Parkinson patients. And then we thought of Parkinson's as only a motor speech disorder. That was the primary symptom complex. And it was slowness, weakness, rigidity, stiffness, and tremor that we looked at. And that's what we expected to see. So when we looked at Parkinson patients, we were very interested in their intelligibility, how well they can articulate. If your tongue doesn't move to the same range or speed, you won't be able to articulate as well. So intelligibility can sound like intelligibility if the tongue doesn't move to its full range. If it does, intelligibility, it's much clearer. I want you to think of the word catastrophe, and I want you to say it. Are you ready? Now, I want you to say it really fast. You ready? Yeah, I heard some catastrophe over here. Catastrophe. The faster you speak, the shorter the range of motion of the tongue. Now, if the tongue was weak, it couldn't get to those different spots as quickly. So at home, you can play with that. Constitution, 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 constitution. And you can actually feel the range of motion. Well, that's all about speech intelligibility. So we could measure that. We could measure the movement of the tongue and how clear your speech was, and we call that tongue range of motion. Then we looked at speech power. We're still looking at speech power. If you have weak muscles of the tongue and the face, you're going to have it of the respiratory system. You're not going to get as much air pressure going out for speech. So we looked at speech power, and you can measure that in decibels. On your cell phone, you can turn to a dB site, an speech intensity site, and you can put it down in front of you, and you can start talking. And if you're talking at about 55 or 60 dB, that's not loud enough. I'm talking to you right now, and if I had a little microphone or my cell phone in front of me at 6 to 8 inches, this was about 65 dB. If I'm talking to you like this is about 75, 80 dB. You don't need it that loud, but many people who have Parkinson's talk very fast. The range of motion is slow. The pressure on the lungs is slow, and this is the speech we get. So speech power is very important. Speech rate seemed to be very fast. Well, that was because the tongue range was so short. Well, that's what we did in 1972. We focused on motor speech, and we could track it. We could take numbers, and we could track how well we're improving the speech. Nowadays, things have changed a little bit. Now we've learned that the loss of dopamine in the brain not only causes motor speech disorders, but it causes sensory speech disorders. It causes memory and cognitive. It causes language. So the activity of the brain is not just motor. It is now sensory. So as speech-language pathologists and as patients with Parkinson's, we now have to focus on much more than just articulation and speech power and voice power. We have to focus on language and memory and verbal processing. And those are the activities that speech-language pathologists will give you to work on. And as a speech pathologist, we have to evaluate articulation, voice, language, cognition, memory, swallowing, because swallowing requires motor speech, requires the pharynx and the larynx and the esophagus to work with some strength, some timing, and some sensory feedback. So it's natural that some patients, second, third, certainly fourth stage of Parkinson's, will have swallowing problems, respiratory problems. Why wouldn't you have psychosocial problems? This is a difficult thing to manage. So we have a lot to look at as speech pathologists, and now our treatment paradigms are a little bit different. Now we're concerned about the caregiver. How much does that person know about Parkinson's? They're going to have to know a lot. You know, Brian's presentation made it quite clear. We have to know a lot about how we're going to modify our home, the bathroom, and the bedroom. There's a lot to know. So hopefully we can find a competent caregiver. Quality of life. You know, we know as speech-language pathologists, we are not going to correct this impairment. We're not going to correct this disease state. We can reduce the severity of the impairment. We can reduce the amount of disability. We can limit the potential handicap by providing certain techniques certain understanding of speech-language pathology, and that's what's very important to us. That's my focus. How do I make sure that your quality of life is as high as it can be? That you can still do in your life what you wanted to do when you were 45 or 50. I know I try to get to see my grandkids as many times a year as I can. They're out in California. That's a long ways away. So the quality of my life is highly dependent on how many times I can get out there to see them. Of course, it's nice to have computers and FaceTime, but my quality of life depends on that. So technology, support groups, critical. I'm so proud of our support groups. You know, and of course, you folks, you all go to support groups. And you're better off, you're more informed, you're more positively motivated, you understand better. The myths that you have about Parkinson's are few because you go to support groups. We got to do it together. We can't do it without physicians, of course. We can't do it without psychiatrists. We need physical therapists, medical social workers, speech pathologists. If you don't have a big team, you're not getting the full care. This is some more information that the big Canadian study brought out, was that memory and thinking disorders, cognitive disorders, are as significant in the Parkinson population as they are in the stroke population. Now, we've been treating stroke patients for many, many, many years, and we know we have to treat not only mobility and walking and speech and swallowing, but we have to treat memory, cognitive disorders. We have to do the same with Parkinson's now. That's pretty obvious to us. So the population of Parkinson patients have as many cognitive and memory problems as our stroke patients. Language disorders. We didn't treat language disorders in Parkinson patients 20, 30, 40 years ago. We didn't know they had them. Now we know that it's a significant problem, that many of the things that we say and remember and articulate are not as completely expressed when we have Parkinson's. We have decreased language comprehension, as if we had a hearing loss. We didn't get all of it. We heard the conversation, but I didn't get all of it. What do you mean? You were standing right there. I didn't get all of it. Kind of like a hearing loss. We have errors of intended meaning. We said that we wanted to go out. Let's go out. Let's go out. Come on, let's go out. What you meant to say was, I want to go out and have dinner and then stop by and see the grandkids. But all you said was, let's go out. So she went outside and you guys took a walk around the lake. Well, this isn't what I wanted to do. Word finding. You know, we all have that as we grow older. So I'm experiencing that. That's no fun. That's embarrassing. You know, I sit around the table at Beaumont with a bunch of my old buddies. We're all looking for words. I mean, we forget actors' names and, you know, the next meeting of the medical staff, and then we're all asking each other, what? But we take it in stride. We know what it is. We keep cueing it until we get it. What if we just said, forget about it? And we didn't ask the brain to search. So the next time you can't think of something, don't give up on it. Get some more cues. Think about it. Put it down in your head. You were thinking of this actor who was, you know, he ran up the steps on the Philadelphia Museum, and he was a boxer, and his name was Maki Laki or something like that. Stay with it, because when you get in the car, you're going to, Rocky Balboa, I got it. Sylvester Stallone. Diminished fluency. You know, I'm pretty fluent now. I'm really jabbering away. Things are coming to me. I'm expressing ideas. I'm moving right along. But sometimes the words don't come so fast. And I forgot where I started. And let's have dinner. What? Thought you were going to wash the dog. Oh, okay, yeah. Let's go take a ride. So the amount of information that we can put out is less. But don't give up on it. You need to practice. We need to give you drills and techniques to practice that. So language is pretty significant. Immediate recall, long-term recall. You know, I can sit down with somebody who's 90 years old and they can tell me, you know, their war experiences. I always ask somebody who's in their 80s or 90s about the day they got married. I say, was it raining? No, it wasn't raining. Was it cold? Oh, no, it was the summer. They remember the weather, the people who came, the things they served, if the liquor was on time. But if you ask them what they had for lunch yesterday, that isn't there. That's short-term memory. Very frustrating. Long-term memory is stored. Short-term memory is stored in immediate processing. So we have techniques and drills that we can drill those techniques so you're not as frustrated. Swallowing is obviously a problem in the later stages. And when muscle movement is slower, has less strength, the timing is a little off, you're going to choke. And the liquids run fast, mashed potatoes run slow. You have to know that. There are ways to handle the liquid. Put a little amount of liquid in your mouth. Maybe put your head down a little bit and swallow. A deliberate swallow with the chin tucked is going to give you a better anatomy for the water to go down. That you did it deliberately is going to notify your brain to do it in sync. But if you're eating pretty fast, you have a high likelihood of having difficulty. Well, we work on those things. We help you manage that situation. In the 70s, we were concerned about rate of utterance, how fast those syllables came, the power, tongue, range of motion, intelligibility. Things have changed, and now we have to be concerned about cognition, nutrition, mood disorders. But for me, I try to find out right away what are the things that you have set up for quality of life. In our inpatient facility at Beaumont, I took out a bunch of the patients who had Parkinson's in 2013. In our inpatient facility, we use the FIMS, a functional independent measure, and all of our patients that come into our inpatient facility, we rank them on 23 different parameters. And these are stroke patients, MS patients, and PD patients. The Parkinson patients are in green, and you'll see that they look pretty much like the stroke and multiple sclerosis patients in terms of those first parameters that you see there. Those are all motor parameters, mobility, raising your hand, standing up, getting out of bed, getting your shirt on. They're all about the same. So if we had a brand new stroke patient or a patient who was in the hospital with Parkinson's, maybe they fell and they're in the hospital, or an MS patient who was in the hospital, maybe they had an exacerbation, they would look pretty much the same as we tested them if they were of similar severity. And then we treat them 8, 10, 12, 15 days. That's all. Then we discharge them. And when we discharge them, we find that the MS patients, they're pretty good. They improved considerably in those latter dimensions. Those latter dimensions that you see are expressive language, mentation, memory. But you'll see the Parkinson patient is kind of in the middle. They didn't do as well as the MS patient. And the stroke patient is down there too. Now what that tells us, and we're looking at that, is that we do pretty well with our patients when we see them in the hospital. We don't get them completely better. But our Parkinson patients don't do as well as our MS patients. MS patients are usually younger, but they do about as well as our stroke patients. What that tells me is that we're going to have to give our Parkinson patients the same attention and complexity and comprehensive treatment that we've been giving our stroke patients. So I told you that the impairment, which is Parkinson's disease, is something that we cannot correct. We can diminish the disability in speech, language, and voice, and that improves the quality of life. So while we still have to focus on voice and rate and utterance, we still have to now look at all the cognitive and mood and all the concerns about working in the community. I try to tell all my patients to make sure the family knows that you have Parkinson's. Make sure your employer knows you're still going to be able to work, but people should know why you have some of these symptoms. So if the patient is very young, in their 50s, 40s, and 50s, we're going to treat them a little bit differently. We're going to increase the power of their voice. We're going to increase their speech articulation. But if they're a more moderate disability, then we're going to focus on language, short-term memory, mental tasking. If they're more severe, we're going to have to focus on their verbal connection and interaction, their psychosocial coping skills. That's going to involve the spouse. And we may have to use some computer devices to help them. And all of these things require a very comprehensive, complex approach to speech-language pathology. And we can't do it without a big team, including the family, including the spouse. I try to tell my patients, don't resist. Accept the fact that you have Parkinson's. Understand it. Learn as much as you can about it. You're going to do quite well if you do. Don't keep it hidden. Just don't decide not to go and visit the grandkids because it's a long trip. You're going to be fine. So, to incorporate all of that. Well, there are other techniques that you can use, and Jenny's going to talk about one of the more popular ones, LSVT.
So I apologize for the first slide. It's a little busy. But one of the first things I wanted to let you all know is that LSVT Loud, it's most effective for the earlier stages of Parkinson's, early and middle stages. So LSVT Loud it was named for Mrs. Lee Silverman, and LSVT stands for the Lee Silverman Voice Treatment Program. It was developed in 1987. And so I'm going to kind of just go through this briefly. You guys can all read this, but essentially what it's looking at is it's a single treatment approach. So Rick talked about multi-treatment focused treatment, and LSVT Loud focuses on vocal loudness. And with vocal loudness, it focuses on intensity and effort within the sessions, and the goal then is that we are recalibrating a normal level of loudness. So by focusing on this single goal of speaking loud, the idea is that it improves the respiratory support, your laryngeal and articulatory function, which maximizes the speech intelligibility. A lot of people have said that, oh, LSVT, it's teaching you to shout. And it might appear that it is that way since the main focus is increased vocal loudness, but it's not really focusing on yelling or shouting, but more so to bring your voice to a more improved, healthy vocal loudness without strain. And so this intensive mode of administration is consistent with motor learning and skill acquisition, neuroplasticity, and these are all critical in achieving maximal results. As Rick mentioned, it's not just a motor speech disorder. We're also looking at improving sensory awareness. And again, the goal is to improve vocal loudness so that we're not stuck with that same quiet voice. So the new louder voice is the voice that's within normal limits. So as I mentioned, LSVT, it focuses on one speech target, and by focusing on a single target, it helps to improve the efficiency of the treatment and simplifies the treatment. Parkinson's is a progressive neurological disease, and cognitive impairments are very prevalent, which is why having a single treatment approach, by having a more simplified treatment program, it is easier to focus on that, learn it, and have improved carryover. So the key concepts are vocal loudness, and the vocal loudness is administered through the amplitude, and it's highly intensive, and we're focusing on effort. So this helps to impact the other aspects of speech, and we're hoping to see a maximum change with minimal cognitive effort. It scales up across the speech mechanism, and it's initiated at the vertically lowest level of speech. So what I mean by that is we're starting out with a sustained vowel. So the main goal is we do a lot of ahs in the session. And so it's easy. If you can produce and sustain a vowel, the ah sound, then you're essentially able to do this treatment. So cueing, increased vocal loudness does not mean we're teaching you to talk loud, to shout. What we're trying to do is get the loudness so that the patient feels that this is a voice that's within normal limits. And we're training healthy vocal loudness. So obviously we don't want a strained, pressed, a too tight vocal quality. We want a good vocal quality. So we want the quality to be good in addition to a lengthier, sustained ah. The goal is always loudness with good vocal quality, as I mentioned just before, and the loudness with the best quality in order to achieve the most efficient voice. And like I mentioned, quality means a voice without strain. It's not pressed, tight, or too loud for any given patient on any given day. So LSVT, one of the main concepts with LSVT is intensity and high effort. So there's intensity across the sessions as well as within the sessions. So LSVT is not for the weak-hearted or those patients who can't commit to a lengthy schedule. It is quite a commitment. It is 4 consecutive days a week for 4 weeks. Within that month of treatment, there are daily homework tasks as well as daily carryover tasks, and those are to be done all 30 days of treatment. Intensity within the sessions, so within each session, and I give a breakdown a little bit later of what each session is comprised of, but the intensity within the session is high effort repetitions, force resistance, increased accuracy, and fatigue. So what we're hoping to achieve is a recalibrated level of loudness for patients. So we're looking at a sensory problem. So vocal loudness that is within normal limits is perceived by the individual as too loud, and that's the sensory aspect of this. And so we're hoping to recalibrate that. Many patients with Parkinson's have a disruption of the internal cue or trigger, so decreased self-initiation, self-monitoring, self-correction. And again, we're hoping to address that to improve that. And the neuropsychological problems that are prevalent with Parkinson's. So the slowed thinking and learning, the decreased attention, cognition, and memory. So what are the goals? What we want to do is help the patient to achieve these things. We want an increased need for increased vocal loudness. to understand that a louder voice is within normal limits, that it's not shouting. We want to see that improved perception of what a louder voice is, to become more comfortable with a louder voice, to build daily increments of calibration, to improve the self-monitoring and the adequate loudness level. And these goals are achieved through treatment activities, education, homework, and carryover assignments. So this is a typical LSVT Loud treatment session. So it's broken down into daily exercises and hierarchy exercises, so that daily exercises always remain the same. And the daily exercises start with a sustained ah. And you can see that what we look for is a good quality ah, and we expect 15 reps. So I'm fighting allergies right now, so my voice is not the best in terms of a vocal quality, but what we'd like to see is for a patient to hold an ah, like an ah, and the main goal is for 10 seconds of good vocal quality. And then we have them do 15 reps. Then we also focus on frequency range. So we do a high ah and then a low ah. And again, 15 reps. So this is where the intensity comes into play here. Then we increase to use of functional phrases. So each patient creates their own individualized 10 functional phrases. We choose this so that it's individualized to the patient. So if a patient is already saying certain things every day, get the mail, things like that that are functional to them, those are the phrases we want to practice, because what we're hoping to see is that improved carryover if they're using these phrases outside of the daily exercises. So the other part of the LSVT Loud treatment session is hierarchy exercises. And so that's broken down into structured reading and then off the cuff. So off the cuff this is conversation. This is where we're trying to bridge the gap into conversation so that, again, the goal is to carry over this improved vocal loudness, improved articulation, intelligibility, outside of just these structured treatment sessions. We also have the patients complete homework and carryover exercises. And like I mentioned before, this is done all 30 days of treatment. Homework is completed more on days that they don't have therapy, and carryover exercises, this is where we're hoping and encouraging the patient to use their loud voice in situations outside of a structured environment. So if they're going to the grocery store, if they're going to the library, if they're in a choir, those are things where we expect them, okay, this is part of your treatment, you have to focus on using this for carryover. And again, this is assigned all 30 days of treatment. So this is kind of the breakdown. Each session is 50 to 60 minutes. The first 25 are the daily tasks, and that's the ahs, the high, the lows, the functional phrases, and then the hierarchy is the next 25 to 30 minutes. And then we spend the last couple minutes focusing on the homework and carryover assignments. And the calibration, that's embedded throughout the entire session. So what changes as treatment progresses? So that's the main goal. Well, what are we doing this for? What are we hoping to achieve? What do we want to see? So we want increased effort, improved loudness, vocal quality, intelligibility, rate, breath support, intonation, and naturalness of how we sound. So calibration to effort and loudness, that's the main goal. Improved loudness and an improved loudness that's within normal limits. And a generalization of a louder voice outside of the treatment room. So this brings us back together. And Rick had stated that yes, I am LSVT certified, but I also do regular, the RMTT program as well. It is based on individual need. Not every patient is appropriate for LSVT, simply because, it is quite a commitment in the beginning, but treatment is individualized, and everyone every patient with Parkinson's is different, and we look at that as a whole.
You have to do it a lot. There's a lot of exercise. You know, I give my patient lots of things to do. And I ask them, I want them to do it in the morning 3 days a week. Well, then they come back and I say, how did you do? Well, we did it once. You know, if they did it every morning and once in the afternoon, 4 days a week, things would happen. So that's just common amongst all of us. How often do we do our exercises? Do we do our homework? You know, all the lectures this morning about exercises is so important. It's just hard to get out there 4 days a week and do the walk. The LSVT requires the patient to work on it every day. I mean, it doesn't come just because you understand it. It doesn't come because you did it once or twice. We used to think that once you had Parkinson's, your brain had lost function, that it could not regain. Like in stroke. We thought if you had a stroke, you infarcted. A lot of your cells in your brain were dead, and they can't come back. Wrong. We now know that there are brain cells that can be rehabilitated. We now know that there are muscles that can be made more active. So much of the research shows if you use it, it'll come back. It doesn't all come back. Who gets it all back? I'm not getting it all back. But if you work on it day after day, and that's what LSVT requires. That's the difference between LSVT and what I do. I don't insist that you do it every day, 2 hours every day. They do. You don't get your money back. So, you know, I don't know how Florence Marks does it. I don't know how Florine does it. How she gets people to come in, you know. I don't know how she does it. But I know that all the people who've lost 100 pounds and they're on TV and they look so wonderful, I know that represents maybe 10% of all the people she sees. 80% of the people who do Weight Watchers quit. Yeah, real. But if all those people did what she asked them to do, you know, you bought all the meals, you had all the meals, you did all the exercise, it happens. So it's human nature. It's human nature. And of course, I'm talking to the choir. You people are wonderful. You're sitting here. It's 3:30, 4 o'clock. You should be out there having cocktails. It's the people who don't come to the support group, who don't come to the conferences, they're the ones I'm really worried about. And so you need to find them. You hear about somebody who has Parkinson's, you need to grab them and say, come on, you're going with me, we're going to support you. And
We have a question.
oh,
I don't mean to interject, but I do want to clarify or ask you to clarify. The cognitive changes that you're addressing or that you've spoken about do not necessarily equate to the dementia that has been spoken about in the prior talks today, correct?
yeah, for the most part.
Because they can be mild cognitive changes, not necessarily a full
But I'm talking
dementia
about
diagnosis.
serious cognitive problems. And dementia is about memory, you know, verbal processing. It's, you know, when we see Parkinson patients at 3rd and 4th stage, we're looking at some dementia.
Sure, but what stage would you say you see cognitive changes start? Do you see them at 1 and 2, stage 1 and 2?
Honing yard is a scaling stage we've used for about 50 years. A couple clinicians put it together. Stage 1 is early Parkinson's. Most people can't even see the symptoms.
Okay.
Stage 2 is some people notice that maybe you have a tremor, maybe you're slow, maybe your speech, but for the most part, you're still working, you're doing fine. Stage 3, things get a little more challenging. And then, of course, there's stage 4 and 5. It's very serious and progressive when you're in your 80s and 90s. Cognitive problems are going to show up at least in 3. But people who are working, I have people who are still working, they're lawyers, they have Parkinson's, and they know their cognitive strengths are not very good, so we do drills. We practice. If I use Sue Brubaker's books on her techniques, and I have my patients do 2 or 3 pages. I want you to listen to this statement. The first soft drink in the United States was Berner's Ginger Ale, and it was made in Detroit by a pharmacist named James Berner in 1866. Did you get that? What was the name of the soft drink? What was the pharmacist's name? What? James Berner. What year? That's the kind of stuff. So Sue Brubaker has a book with 200 of those. Interesting, one-sentence, loaded information. I tell my patients, I want you to do 20 of those every night with your spouse. And then when they come in, I shut the book and I start asking them all these questions. So how come you don't remember that? Well, we didn't do it. Well, you're rehearsing the cognitive skill. Memory, association, meaning. The most important cognitive drill any of us can do is reading. If you read something and you share it with somebody, that's high-level cognitive skill. Newspaper, magazine, book. So I tell them, I want you to read something that you enjoy. I want you to share it with your spouse. And when you come in next time, we're going to talk about it. Those are the kind of skills they need. You need to rehearse it.
The importance of a caregiver is huge. Rick said twice, spouse. Doing a lot of these skills, these treatment tasks, activities with another person are huge. We really rely a lot on caregiver support, especially as the cognitive skills decline, because we're asking for other people to help to carry over what we're doing outside of the structured treatment setting. So that's hugely important.
She's coming.
I just wanted to add to your comments and question. Things like word finding and verbal fluency, we've probably all had moments where we had trouble with that. So even though, like you said, very farther on in the process of the disease, you're more likely to see more of these things. Many patients with Parkinson's are having sleep problems right from the get-go, or having depression or anxiety right from the get-go. So that really does and can affect verbal fluency and word finding and some other kinds of attention related and memory things. So even though, the progression toward dementia is more likely at the end phase, I've seen many patients who early on are having at least minor verbal fluency issues. And what we do in our profession is try to determine the difference between something that's more chronic and more representative of actual brain connective loss, as opposed to environmental factors or other diagnoses or medication effects somebody might have. So I think you can see it quite early. It depends on the person, but it would be milder.
I have a question regarding calibration. Do you offer any tools, technology-wise, that can assist the feedback for the patients to see what the calibration is and how the loudness is projected? Because I think it's very subjective for them to understand.
Absolutely. So Rick had mentioned technology earlier on in this presentation. If you have a smartphone, an iPad, there are some decibel reader apps, which are great to put on there. There are dB readers that you can get from, gosh, is Radio Shack even still around? In any electronic store, Best Buy sells them, and they're not that expensive. You can find them on Amazon for under around $25. So, and this is nice. Now, through the LSVT Corporation, they also offer something called a companion, which patients can order, and it records all of this. They can do all of these treatment activities right into a computer and do it that way. That's a little more expensive, so you get the continuum, but yes, there are lots of tools, so it's more objective.
Okay, one more question. Oh,
I wanted this gentleman just to ask this question.
sure. Listen to me.
Say,
Sure.
it's a little late to stop the revolution. Would you say that? Now, I want you to say that significantly louder, as if you were hollering at somebody. That's not enough. I want you to say it louder.
It is little late to start the revolution.
Excellent. Now I want you to take that same sentence. It's a little late to stop the revolution. And I want you to pause after late. It's a little late to stop the revolution. So you pause after late and you pause after stop. Say loudness.
It is little late to stop that revolution.
Oh, the revolution was a little fast. Tongue, range of motion. So on revolution, you have to take more time. It's a little late to stop the revolution. Ready?
It is little late to stop the revolution.
So, got loudness, phrasing, tongue range of motion,
It's not that important.
improved intelligibility. Now, if you would do that 5 times every day for the next 22 days, your whole family's going to know that.
We have a question in the back.
So is it my understanding that you recommend LSVT Loud for everyone as soon as they're diagnosed with Parkinson's disease? And if so, is it covered by insurance?
So I don't recommend it for every single person, but it is covered by insurance. Some insurances, for the most part, because it's coded as a motor speech disorder. So it depends on what individual insurances are. It's 16 treatment sessions. So depending on what your insurance allows coverage-wise, we look at that. The other kind of caveat to think about is with Medicare, physical therapy and speech-language pathology is under the same little pool. Now that there are changes with the therapy cap, we don't have as many of those issues, but we are still cautious of that, and it's individualized. You know, if a patient says, yes, my speech, I'd love to improve it, but my major priority now is physical therapy, and I don't want to pursue that now, then that's something we are supportive of. But we look at all insurances individually and look at that and then go from there.
We have a question over here, too.
Actually, it's quite related, but a lot of the literature has been saying that you should be tested for the need for loud early in.
Right.
Well, how do you know if it's necessary? Do you do an assessment first so if I don't need it, I wouldn't be signed up? Or
So after you're diagnosed with Parkinson's, you know, Rick and I have talked that, you know what, so you see your neurologist and you go in and you say, I've got a diagnosis of Parkinson's. We know it's a progressive neurological disorder. We know what can happen down the road. So you get a referral for an evaluation. You go in, you do the evaluation, PT, OT, speech, and you get your recommendation. If you need it, then we recommend treatment. But if not, it's an evaluation. We give you some compensation, some education, and then you can revisit that down the road. You know, the beauty is we're here. we're available, and we want you to know that this is a resource that you can use at any time. You know, I have a lot of Parkinson's patients who they come back yearly for a refresher course. They might not necessarily go through the entire LSVT program, but we might bring them in for 3 to 5, 8 sessions and focus on the compensations and the strategies, and then send them on their way. So a referral for an evaluation is great. Does that answer your question? Okay.